So our next speaker is Dr. Shelley Chapman. And Dr. Chapman is a maternal fetal medicine specialist who comes to us from the Greenville Health System here in South Carolina. Dr. Chapman did her medical training at the University of North Carolina at Chapel Hill. And I didn't realize until I read her bio that she's a native of Winston-Salem. So she did her training in OBGYN at the University of Florida, and then her fellowship in maternal fetal medicine at the University of Alabama at Birmingham. She's been with Greenville Health System since 1997, and she's going to give us the prenatal perspective on birth defects.
Great. Is that working? The lavalier? Okay. First of all, let me just say I am honored to be here. As I was coerced into doing this by my friend Dr. Rogers, I realized that I was getting a little intimidated working on the what I was going to kind of say to you this morning, because when we have questions in maternal fetal medicine, we'll go to a geneticist and tell them what we're seeing on an ultrasound, or give them a fragment of DNA, and you guys tell us the answers. So this is like, you know, talking to people that have the answers. It's sort of like a surgeon talking to pathologists. So anyway, what I decided to do, which I hope is very complimentary to what Dr. Skinner just presented, is just to tell you what we do every day clinically in our office in terms of ultrasound, prenatal diagnosis of birth defects, and kind of where we are with that. The technology over my career has changed tremendously in terms of what we can see on ultrasound and the details of what we can see. I thought we'd go through some normal things both in the first and second trimester. And then look at some abnormals, and we'll have some audience participation, hopefully. And if the time cuts us off, we'll just cut off halfway through the talk, because it was designed to just be as long or as short as it needed to be. So anyway, let me hit all the right buttons. So most of this is going to be 2D imaging. This is a 3D image with our ultrasounds, and rather than highlight the ultrasound techniques, I just want to do what we really do mainly, which is 2D ultrasound. But this is a 3D ultrasound. This is why parents love ultrasound, because they can see, this looks like a baby. And particularly patients that have babies that we're concerned about birth defects, it's great for them to see this type of image where they can see, oh, my baby's not going to look like a monster, because that's what they think when we tell them, oh, there's a heart disease, oh, there's a cleft lip. You guys are astute. We're going to come back to this little child at the end, and I'll let you tell me if you can guess what the diagnosis is on this. So in the first trimester, the first thing we want to do is to make sure that the baby is in the uterus. So it's not an ectopic pregnancy. And then you can see at the bottom the M mode to diagnose that there is a heartbeat. So that's the first thing we do in the first trimester. And then we look at the yolk sac, which actually has genetic importance. It's not a fetal part, but a large yolk sac over 6 millimeters is associated with an increased risk for fetal aneuploidy. So in our women that are advanced maternal age or have other reasons to suspect aneuploidy, having a normal yolk sac is encouraging. We can say, hey, this is looking good. This looks like things have started well. There's actually a paper that if the yolk sac is over 8 millimeters, 100% of those women lost their babies in the first trimester. So it's a very good thing to reassure patients with. So in the first trimester, one of the most important things we do is establish the dating criteria. So we do a crown rumple, you can see the measurement here, to decide what the due date is. That's extremely important in terms of looking at an increased risk for aneuploidy, increased risk for viral infections. As the baby grows, do they stay on their growth curve? So that's one of the most important things we do in that first trimester. Right here, I put this picture here to show you the amnion. We can see that up to 14 weeks before it gets plastered to the side of the uterine wall. And that's important when we start looking at nuchal thickness, nuchal translucency. You guys are very familiar with first trimester screening that we used to do a whole lot of before we had cell-free DNA. In the first trimester, we can clearly see the shape of the head. We can see the cranial bones. We can diagnose anencephaly in the first trimester because if they don't have these cranial bones, we get suspicious. You can see the midline flocks. You can see the lateral ventricles filled with the choroid plexus there. I put this here to remind me that this is the abdomen, to remind you of something that we frequently get consultations on. Is there a ventral abdominal wall defect? But there's a process of physiologic mid-gut herniation that occurs in the first trimester between 8 and 10 weeks of pregnancy, where the intestine enlarges and elongates and goes into the base of the umbilical cord. And then as the abdomen continues to grow, it goes back intra-abdominally. But we frequently get asked this in the first trimester, and this is just an embryologic normal finding. All right, nuchal translucency. An increased nuchal translucency has been associated with aneuploidy Down syndrome and also with an increased risk for cardiac defects. It used to be that we would do this every day, all day in our office before cell-free DNA, combined with a PAP-A in the maternal serum and an HCG, and prognosticate the mother's risk for Down syndrome. This one measures between 2 and 3 millimeters, which is sort of an equivocal range. Now we use it more in the setting of our patients that have significant metabolic diseases like diabetes, where we know there's increased risk for cardiac disease, because if this is normal, we can again reassure them. We can see the heartbeat, we can't see all the details, the blood vessels and everything, but we can say, hey, it's in a normal range. This decreases your risk for a baby with congenital heart disease, which we know you're at risk for because of your diabetes. This is a very pronounced thickness, cystic hygroma. I have one more picture of that you can see right here. Again, associated with several different genetic conditions like Turner's. We also see it sometimes with children that have other aneuploidies. It can be a sign of fetal hydrops to come, and you can have lymphedema that causes this. And then I put this in here just to remind you, the other thing we can see in the first trimester is how many babies. So are there 2, are there 3, are there 4? And we can look at not only the number of babies, but we can look at the amnions, we can look at the yolk sacs and see whether they share placentas, what type of twinning they are, and those are very important as we look long-term at vascular supplies that may affect the fetal birth defects. And then I just wanted to mention one of the invasive procedures that we sometimes do in our office, chorionic villus sampling. This is done between 10 and 12 weeks of pregnancy. We actually do it transabdominally or transcervically, and we get placental tissue from the fetal side, from the chorionic villus, that you guys then look at and tell us the answer in terms of looking at the chromosomes. And it's been really nice in the era of cell-free DNA testing. We've been able to kind of tailor which women are offered invasive testing. You know, this is not without potential for complications. About a 1% risk of miscarriage. There's some question about whether there's an increased risk for limb defects. So if you don't have to do an invasive procedure, that's great. And so we've been able to do far fewer of these now that we have a screening test that's a little bit better than maternal age. All right, shifting to the second trimester. These are normal findings to begin with. Ooh. So, again, you can see the cranium, you can see the midline structures. This is the cavum septum pellucidum. Very important in seen in every patient so that we can assess the integrity of the corpus callosum. Here, the ventricles, the lateral cerebral ventricles we can measure, and a good rule of thumb is anything less than 10 millimeters is normal in the brain. So a lateral cerebral ventricle that's less than 10 is normal. Ventriculomegaly is what we would be looking for, that's associated with things like neural tube defects and a number of various syndromes. So looking a little bit more posterior in the brain, this is the cerebellum. Some people describe it as dumbbell-shaped, figure-of-8 shape. They're making sure that you can see both hemispheres, that they're not splayed, that we can see the vermis intact. This is the nuchal fold that we measure in the second trimester. Again, an exaggeration over 5 millimeters is associated with an increased risk for fetal aneuploidy. It's a picture of the face here. You can see the eye sockets on either side. You can see the lens there. We can diagnose fetal cataracts at this age, which we sometimes look for in women who have had exposure to various viral illnesses that may be associated with birth defects. Right here is the upper lip, the philtrum. You can see intact there. Try to get this image in every child. Obviously, you mentioned that this was one of the more common birth defects. We're pretty good with cleft lipping, not as good with just isolated cleft palates, particularly if it's a soft palate, although we do have the capability to look in families that have that history because it tends to be familial. We always check the size of the fetal abdomen as part of our biometric measures in the second trimester. Most of the fetal abdomen, this is a cross section, so like you'd see in the CT scan. Most of it is the fetal liver, and so that's why in women that have diabetes that's uncontrolled, that baby's processing all of that extra glycogen sitting there in their liver, and they get these fat little abdomens. This is a stomach bubble here. It's a single isolated cystic structure, no double bubble like you might see with a baby with Down syndrome that had pyloric stenosis or duodenal atresia. This right here is the umbilical cord coming in, again a cross section through the abdomen, the spine's back here. We want to make sure that there's nothing herniating here, that there's no tissue outside this ventral abdominal wall. Moving down the fetus in cross section on either side of the spine here, you can see the 3 echogenic centers that make up the vertebral column there. You see the kidneys, and you have to use your imagination. But there's no cystic structures like you might see with cysts. There's no dilation to the renal pelvis like we see with hydronephrosis. And I'll come back to the kidneys in a minute. So, neural tube defects. This is the lumbosacral area, which is the most common place for us to see a neural tube defect. And what we look for in the coronal view are these vertebral bodies that come down and then sort of point at the end. This is a normal lower spine. I had some really good pictures of the spine, so I may have taken too many. Here's one in a coronal view. You can see that when we do have a neural tube defect, we can actually count, these are ribs here, we can count exactly where it is and tell the neurosurgeon, hey, we think that the defect is from, T4 to L4, so pretty detailed. This is farther down, transverse section in the pelvis. We measure the hip angle, which is one of the soft markers for Down syndrome, so we can measure that and make sure that it's within normal range. Back up in the chest, we look at the heart on every baby in the mid-trimester because of the increased risk for heart defects, as Dr. Skinner alluded to, looking for this 4-chamber view where the atria and the ventricles are equal size, looking at the wall thickness, making sure there's no VSD or ASD. Color flow helps us a lot with this, but it's been published that in babies that have congenital heart defects, 90% of them will have some abnormality that can be identified just on this simple 4-chamber view, so this is an exceedingly important view to get. We can see the outflow tracts, the right ventricular outflow tract here, the left ventricular outflow here with the integrity of the septum. This is not quite as clear in the lighting here, but you can see, and it probably would light if I had the color on, color Doppler on, but you can see the ductal arch. It's more like a hockey stick. And then this one, I think you can see much more clear. It's like a candy cane. This is the aortic arch with the vessels that go off, the heads up here. So again, looking for coarcts like you might expect with Turner syndrome. All right, this is the diaphragm here. Fetal head's this side, heart's here. This is the bladder. This is the liver. Again, looking for the integrity of the diaphragm, being sure that there's not a congenital diaphragmatic hernia. This is the fetal bladder and cross section. The spine's here. We look for both umbilical arteries coming through. Single umbilical arteries are again associated with the increased risk for fetal aneuploidy. So seeing this view is important in terms of looking at issues that might affect the patient's risk for a baby with a chromosome anomaly. All right, I did take offense at one thing you said, Dr. Skinner. We are really good at making sure both kidneys are there. But he's right. This is in the last 5 years, we've gotten much better at interrogating the fact that both kidneys are there. These are the renal arteries, and we make our sonographers get pictures of the renal arteries on both sides to prove that there are kidneys. You can get full. The adrenal glands look a lot like kidneys if you just see them on cross-section. So now that we're looking for this, we're finding more pelvic kidneys and more isolated renal agenesis. Certainly, if there's bilateral renal agenesis, they usually show up with very low amniotic fluid because the amniotic fluid is produced by fetal kidneys once you get into the second trimester. Okay, this is why parents come to our office. They want to know what they're having. Now, you guys have helped the cell-free DNA. They're finding that out much earlier. We just confirm it. But certainly in terms of looking at birth defects, now, every once in a while we'll see a hypospadias. That is not one that is very common to see on ultrasound unless we turn on color flow and catch the baby urinating and see that it's not coming out of the tip of the penis. But there are certain birth defects associated with sex-linked genetic conditions, and so sometimes it's really important to know, is this a boy baby and is it a girl baby? Because I might have invasive testing, an amniocentesis or a CBS, to look for something if it's a male fetus. So the genitalia is not only important to parents, but it's important for us when we're assessing risk for birth defects. So this is the little pornographic picture of a little boy. We can look at all extremities, both in the first trimester and the second trimester. This is the right lower extremity. You can see both of the bones here, the knees here, and then you can see that the foot's coming off straight. We can see arms and legs, the presence of all the bones. We can count fingers. In terms of looking for soft markers for Downs, we look at the 5th digit and make sure it doesn't have a hypoplastic 5th digit. We can look for polydactyly, both in the hands and the feet. And then just to remind you, these are some of the soft markers associated, not all of them are soft markers, some of them are actual birth defects associated with fetal aneuploidy. And these are all things that we look for on a second trimester scan. So the nuchal thickness we talked about, cerebral ventriculomegaly, a hypoplastic nasal bone, an echogenic intracardiac focus, which is just a bright spot on one of the heart muscles, Plexus cyst, which are very easy to see, and I have a slide demonstrating that in a moment. Short and long bones, highly active cysts, echogenic valve, single umbilical artery we talked about, the sandalfoot gap, splayed hip angles, clenched fists, rocket bottom feet, strawberry-shaped skull, and enlarged cisterna magna. So those are all things that we look for as maternal fetal medicine specialists when we're doing scans in the mid-trimester. All right, this is the interactive part. I'm going to put some pictures up and let you just yell out, what do you see? So for the dysmorphologist in the room, they ought to get this profile view and what I'm getting at that's unusual here. This is the forehead, this is the nose. Yay! Micronathia, great. So, very important when we're looking at babies that might have trisomy 18, Treacher-Collins. I'm sure Dr. Hall could list a whole list of things that might be associated with micronathia. All right, what about this one? This points to an area here, upper lip. Exactly. So you've got the lip here, you've got this defect right here, and then it continues. So that's the upper lip. So there's a cleft lip there. Again, associated with a number of different genetic abnormalities, as well as in isolation frequently that runs in families. You can see it. This is one of my 3D pictures that I decided to put in because it actually does help patients to look at it in 3D. That last picture, you can probably make it out just much more clearly. All right, so skull, measuring here the lateral ventricles, and remember I told you anything over 10 millimeters was abnormal. So this is bilateral ventriculomegaly, like you might see with a neural tube defect. It is obviously associated with a number of syndromes that would not be diagnosable until postnatal life. Right here, I put this here because you can see the third ventricle. We don't typically see the third and fourth ventricle, but sometimes with certain abnormalities, aqueductal stenosis and that kind of thing, we can see the third and fourth ventricle. This sort of has a round shape to the head too, which can be associated with various syndromes. All right, front part of the head, back part of the head. What's the defect? Dandy Walker. Dr. Rogers has seen a lot of this. You shouldn't be answering. So this is a splaying of the cerebellar hemisphere here, and there's a defect here in the vermis. What about this? This is the front part of the head, back part. There's lots of the skull there.
Yeah. Is it cranium?
Encephalocele. Woo! So there's brain herniating outside the occipital region of the head, which is the most common place for us to see these birth defects. This is one we hadn't talked about yet. It's in the chest.
Diaphragmatic hernia.
Oh, that's coming.
Okay.
So this is a cystic adenomatoid airway malformation. They appear as sort of an ecodent. Sometimes they can have more cystic appearance, but they frequently will shift the heart towards the right in the chest. We follow these. Many of them have significant issues with high drops and things that become more apparent later. And it won't take a lot of time since we're running out of time. Okay. This is a section through the fetal abdomen and cross section, and then there's this stuff. Floating free, and then gastroschisis, yes. So you're right, we're seeing an uptick in gastroschisis, particularly in young women, less than 20. This is the other ventral abdominal wall defect that's covered by cystic structure at the base of the umbilicus, so an omphalocele. I often ask my students, I'm like, if you were a fetus, which would you rather have, an omphalocele or a gastroschisis? Gastroschisis, right? Because omphaloceles are much more likely to be associated with profound chromosome anomalies and other birth defects. These are a cross-section of the fetal kidneys, and you can see the renal pelvies are dilated here, as you would see in hydronephrosis. So reason for hydronephrosis, we've got what's called a keyhole appearance to the bladder, where there's a bladder outlet obstruction. And when we see these, we can actually tap the fluid in the bladder to see how the kidneys are functioning. And if they're still functioning well, we can actually put a shunt here and allow fluid to leave the bladder during fetal life, allow pulmonary maturation from amniotic fluid being normal, and then this can be corrected postnatally. shape of the head here?
That's a neural tooth
Jennifer? Strawberry shape? Strawberry shape of the head. So trisomy 18. I'm coming to that, Dr. Rogers. So this is a cord plexus
It's hard for
cyst.
me to tell a lemon from a strawberry.
I know, they're very subtle, lemons and strawberries. This is a cord plexus cyst. They do have an association with trisomy 18. We also see them in 1% of normal babies, so we have loved having cell-free DNA as a tool to reassure these patients, because when we see these in isolation, the risk is about 1 in 400 for trisomy 18, and having a normal cell-free DNA allows us not to have to do an amniocentesis on these patients. All right, congenital heart disease. These are your 2 ventricles, 2 atria, and then there's this defect between the ventricles, so a septal defect there between the ventricles. Clenched fist, like you might see with trisomy 18. Amniotic bands you mentioned. These are both feet, and there's some toes, the upper part missing here, and we see that sometimes with amniotic bands. You mentioned this particular split hand foot. We see that. The reason we knew what this was is because we had a great genetic counselor, might have even been Jennifer, who talked to this family and got the history that this was a common defect in the family, and so we didn't freak out when this was found on ultrasound. All right, so lemon on this one. And this is a neural defect. We see a lemon shape to the fetal skull. We see the cerebellum in this banana shape. We're all about fruit. So there's not that dumbbell shape. It's sort of flattened. This is where the defect was, down in the lumbosacral area, which is the most common place for neural tube defects. And you can actually see how the skin is raised there, and then they've got the cystic structure, a little close-up of the same defect. This was what happens downstream in the lower extremity with these neural tube defects. We can get clubbing of the foot. All right, whoever said diaphragmatic hernia, here you go. Here's the stomach and the heart in the same view with a cross section. The valve has actually come up into the left side and pushed the heart to the right. This one didn't show up well. We'll skip that. I'm showing coplanar valves here associated with Down syndrome and AV canal defects. This is a single vessel coming out from where the ventricles are. Anybody? Very good. All right, towards the end here. This is a rib with an unusual configuration.
Oh, wow.
Osteogenesis imperfecta. So we can see shortened long bones. We can see fractures of long bones or ribs. We can see demineralization. You guys are the experts. Whenever I have a skeletal dysplasia of any kind, I just tell them what I see, and one of our smart geneticists tells me what it is. This is just another example of a fractured small humerus. And then just to remind you, we can see the details in terms of the vertebral bodies to know if they're hemivertebrae. We've gotten to that level now. I think this is the last picture, and this is just not a fetal picture, really. I'm looking at the amniotic fluid, which is generous, but it's just to tell you that we have other clues besides the baby. If there are anomalies, we see polyhydramnios in association with aneuploidy. It can also be associated with anything in the GI tract that there's an obstruction, whether it's macroglossia or a TE fistula that we might not be able to see on ultrasound, duodenal atresia, pyloric stenosis. We can also see it with neurologic abnormalities where the kid's not swallowing the fluid appropriately, so we kind of have to dig down when we see polyhydramnios and figure out what is it about this baby that's allowing that to occur. Just like CBS in the first trimester, we are able to do amniocenteses in the second trimester and give you guys fluid. We're doing less and less of those. I was talking to Barbara before the meeting. Unfortunately, because we like doing procedures, cell-free DNA has allowed many patients to forego the invasiveness of an amniocentesis, about a 1 in 600 risk for miscarriage.
All right.
Questions? I've run over my time already.